Welcome everyone who was able to register and join to this next episode of our podcast. And on the other side from London, I have Dr. Elton Dorkin with us. Elton, can you hear us and can we hear you? Not yet. Okay. So then while you are sorting out your audio, I'm going to quickly set the stage. So for those who are joining for the first time, this session will take about an hour and the last 15 minutes is reserved for questions. So questions and answers. So if you have any questions, you're welcome to post them in the Q&A tab of this Teams meeting. If you have already posted it in the chat, that's also fine. And then in the last 15 minutes of the meeting, we're going to go through them systematically. Dr. Dorkin will answer, and otherwise I will do that. And with that said, so you can ask questions during the chat, but we won't get to them until the end. With that said, I would like to introduce my guest. Elton and I go back about 8 years, but we started working together in 2021. And at the time, he was the head of health for Anglo American. And now he's at Rio Tinto. So Elton, hopefully the audio is sorted.
Yes, so you should be able to hear me now. I hope. I'm on fail option number 3, which is to go over onto my phone. So apologies to everybody. We did some prep work and everything was working, and then something went wrong. Okay, so sorry about that false start.
No problem. We can hear you loud and clear. So thanks so much, Elton, for joining us, for making the time. I know you are a very busy man and you look after the health and the lives of thousands of people every day. So we don't take this for granted. Maybe I thought you can probably introduce yourself better than I can. So the floor is yours. Anything and everything that's relevant to this conversation. Thank you.
Thanks, Wim. Yes, Wim, I did catch you, the first part where you mentioned that you and I, we probably met in 2018 sometime, and then got to work together quite successfully, I might add, during the COVID pandemic. And, many thanks. I don't often get a chance to tell you, especially in public, what a contribution you made, but it was really good. So I'm a medical doctor by background, so to start with an introduction, and studied in Durban in South Africa, which is on the East Coast. I'm not sure how much of your audience is. You think most of your audience is South African based? So
yes, but not only South African. So we have a very wide international audience today.
So I then need to explain where Durban is often, but so it's a beautiful coastal town on the east coast of South Africa, where I was born. And I think we studied, started my occupational health career, I guess, in 4th year, as part of, we did community health as part of our Big 5. I think that's what started my career off, at least having an awareness of occupational health as an undergraduate. And I grew up in the South Durban Basin. And if you know much about that, you'll know that through apartheid, spatial planning, there was a large labor, most of the labor for the South Durban Basin with oil refineries and a number of factories in that area meant that it was quite an environmental health hotspot. So I imagine a lot of us got into this profession on the back of some of our own personal experiences growing up in some of those areas. And I think thereafter did my postgraduate qualifications at WITS in occupational health. And then an MBA later on in my career. I think that's probably where I rediscovered statistics in the business sense, you know, and I always say, a lot of doctors do their MBA to get out of a career in medicine. And that was really my intention. You know, I was planning to leave that at that stage, but felt that my skills, you know, business and medicine, a doctor I'd be more competitive than trying to compete in the big bad world where I don't have any advantage as a doctor. But I must say that MBA really reignited my interest in data and understanding data and using it more effectively. And then most recently, I've qualified. I hold a licentiate from the Faculty of Occupational Medicine in Ireland, or the College of Physicians of Ireland. And I'm a fellow of the American College of Occupational and Environmental Medicine. And so work-wise, I got a scholarship from Anglo American, a mining company, in my last 2 years of medical school. And that's how I got into medicine more generally. The company ran large clinical health services. So in the Central Free State, where the largest gold fields in the world are, I worked at the second largest hospital in the Southern Hemisphere. Hard to imagine that. Okay, the biggest is Baragwanath Hospital. The second biggest in the 90s and 2000s was Ernest Oppenheimer Hospital in Valcom. And so it was a lot, serving only mine workers, 80,000 mine workers, and something like 8 or 9 deep underground gold mining shafts. And from there, went on to the platinum business. I then worked for a company called International SOS, which is a provider of outsourced occupational health and other services in remote settings. And after a career in agro-processing, that's sugar manufacturing, growing and manufacturing in Durban, where I was the chief medical officer for Ilovo Sugar, I came back to the mining industry where I'd started my career. And that's where I've been for the last, 6 years now, Wim? I hope that captures most of it.
Yes, and then even more recently, you moved to London. Yes?
Yes, I did. So for career advancement, but also I think the UK has got quite a vibrant occupational health community, and academically, there's a lot going on in the occupational health space in the UK. And I got to move to London about 3 years ago in May, you know. So I'll be here 3 years, initially for Anglo American, and then moved over to Rio Tinto. A little bit about Rio Tinto. Rio Tinto is a multi-commodity miner, okay, but would mostly iron ore is about half of the revenue of the company, and followed by copper and aluminium, and most recently lithium. We the world's third largest miner of lithium. So both particularly aluminium has got quite an interesting environmental health profile. So quite interesting exposures. So.
Thank you for that extensive explanation. So one of the things that became clear very early in our working relationship, and I think you already mentioned a few things that reminded me of this, is that you are not shy of wearing many hats. So you've seen enough patients to really. So we both studied medicine, but I ran away from clinical medicine even before I graduated. So I can't really say that I'm a doctor. I am somebody who did med school. That's not true for you. You actually saw a lot of patients, and you can put yourself in the shoes of a clinician. But at the same time, as occupational medicine, you have been trained, and your practice is to look after cohorts of people, where you cannot really get into the specifics of a single case, because there are 60,000 cases, and you need to make abstraction and zoom out and say, well, yes, there's variation, but also there are things that put them in the same group, by exposure or by job title or by some other. And then on top of that, as a occupational medicine specialist, you are forced to also take on account of the health economic aspects, the ethics aspects, the legal aspects of the decisions that you make and of the risks that you choose to accept or not. So can you maybe say, I know that's quite a messy and a complex space, but what's your approach to navigating all of these different lenses that you kind of have to adopt to do your work well?
Yep. Firstly, with difficulty, I think with so let's start off with the first question about looking after individuals and populations. I do believe that that is the central challenge of most medicine. You know, a lot of people think you can practice either or. You know, you get people who spend their time in the population health space, and then you get people who spend their time in clinical practice. And I like to think, and you're right. You know, I did have an opportunity to practice medicine. I did have a chance to do and in really good systems, you know, and I credit a lot of where I am today for the kind of initial experience that I had in a structured medical setup in Anglo Gold, which, you know, I often say to people, I'm always trying to get back to what we used to do rather than try to do anything new. So, and then coming into the occupational health world, where you're looking after the health of populations, but they're also individuals. And in fact, they're my colleagues. You know, we are all employed by the same company. I bump into these people when I go onto our sites and I see them. Your patients are if you want to call them that, you don't really think of them, they're your colleagues as well, you know. So you need to be doing the best you can for them and for their health. But often the interventions that you put in place. So let's take noise exposure. You know, so you'd imagine that about 20,000 of our employees are exposed to noise above the exposure limit. Now, not individual one-on-one. You're not going to help people by having those kind of efforts. Counseling, telling them to use their PPE. Of course, you know, you need to do that. But that's not what's going to change the dynamic. Changing the dynamic is changing a method of work, a type of exposure, or taking what we call the hierarchy of controls. That's what's going to lower that risk for a whole lot of people. So I think all doctors, you kind of have to choose, you know, do I want to have one patient and see one patient after the other and build a practice, and maybe I'm looking after 5,000 people eventually in some form in a good big practice, or do I want to look after big and put in place big interventions? But it's also something you need to keep reminding yourself why you're doing each one. And when you're thinking what's good for the population is not necessarily good for the individual. What's good for the individual is not necessarily good for the population. How do I get the balance right? And I think that's a central challenge for most aspects of medicine. How do you use randomized controlled studies in practice? Because a randomized controlled study is a population health tool. You need to apply it to your individual patient. Do they match that cohort, you know, and so on and so forth. So while it is an important question, the second part of your question is, as with all health systems, you know, money or finance plays a role, you know, and in our case is a third one, and that's operations and business and what it is that we're doing. We're mining, and we provide the commodities that this world needs to operate, you know. So you can imagine, without your cell phone, without an aeroplane that is made of aluminium mainly, without iron ore, we'd have no homes, no buildings, we'd have no surgical instruments. Without copper, all of the machines that we look at, the computers, but also the hospital, that's all of that is mined by people and needs to come out. So we need to balance this, all of these various considerations in the best possible way. Do we always get it right? I don't think so. And I think we can all share stories and war stories about what's the right balance. But it doesn't even at a country level, how much money you spend on providing a health service, you know, the provincial and state services takes away money from providing jobs or social services. So everybody's balancing a number of considerations. And probably the most important thing is to be aware of these balances and trade-offs that you're making and try to do them in as intelligent a way as possible, and be humble and open to change and improvement, and knowing that just because the system is the way it is doesn't mean that's the best way it can be, and what you can do to change and improve it. So yes, and I think health economics, but not just health economics, economics in general, drives the world, and you need a good understanding of that in medicine.
Thank you. Okay, so I'm going to try to transition to the theme of this conversation, and it's supposed to be all about big data and advanced analytics. And
Yes.
so far we've been talking a little bit about the challenge of balancing individual health and population health, and what it means to look after people that are your colleagues and that are employees doing an economic activity that has consequences if it's being done less efficiently, for instance. When the last thing you said about we doing our best, we can't be sure that we're doing it optimal at all times, but we're doing our best, and we're being humble and transparent about it. That transparency, I think, means that we need to at least capture what we're doing. We need to document it, and we need to report it, because it's bad enough that we have this infinite number of choices and we don't have the time or the money to do all the experiments before making a decision. So we kind of flying the plane, and we're making decisions on the fly. But at least we need to then be transparent and clear on what we've decided and what the consequences are. So with that, in occupational health and industrial hygiene, there's an entire science and practice around measuring exposure, measuring health outcomes, and all the in-between intermediate process indicators at the patient level, but then also, as we were discussing last night in preparation for this talk, measuring things that are not attached to humans, but that are attached to equipment and to environments. So sensors can measure one thing once a second or once a day, whatever it is. Before you know it, you capture millions and millions of data points. Can you maybe share with the audience, from your perspective, what does it mean to be capturing so many data points? How do you go about it? Has it changed a lot since your early days? Do you feel that move towards big data, and what do you do with it?
Yes. So the data has always been big, it's just what you did with it. So that's quite a. So let's take, probably the best is to, especially for people who are technically, who are not in this field without being. So I don't want to get too technical about it, but at the same time, there are some interesting aspects of occupational health. And occupational health is like a large-scale epidemiological study being conducted in real time all the time. Okay, so we're getting into a workplace, we're doing a risk assessment, and trying to understand what exposures are present in this workplace. And and you talk about transparency and truth, and I think that's probably a really good thing about the occupational workplace, because many other spaces don't do that. Okay, you can imagine the noise level in a mall. Okay, it's typically people. The measure is comfort, or whether people come or don't come. So, but there are many other areas where your health. But in your air monitoring is another good example, perhaps, in developed countries. So now on your iPhone app, you can pick up air quality indicators for most major cities, but not all. Okay, so that's the kind of stuff that we are doing in the workplace, but we're doing it across the air plus all of its components. and then things like noise, physical hazards, vibration, both whole body vibration, as in a truck or a vehicle. Now, I'd say in your car, you're probably not measuring that, okay? But often it's not what we see in the industrial setting anyway. So you don't have to, okay? But aeroplanes are probably a good example for me. Aeroplanes, I find them quite loud. And I wonder, if you just sit and listen to how much background noise there is in that and how much exposure, exactly what level of noise are you being exposed to as you take that transatlantic flight? And things like radiation, so you're sitting up in the atmosphere and various types of radiation, including radon and that kind of thing that you're exposed to in that vehicle. So just think about that, but then bring it back to the workplace. But take noise as an example, okay? A sound meter, we need to measure, in order to get an accurate sample, about 5% of people who we believe are exposed to noise. We need to do that at least quarterly if you're in South Africa. By law, you need to have taken 5% of samples. And if you look at that data, you're collecting a noise result every 15 seconds, normalized to 8 hours, So often you don't get the full 8 hours, but you need to normalize it to at least, so the most you could do. So calculate how many data points there are just in one day's monitoring for one individual for noise. It's a lot. Do the same for dust and air constituents. That dust, you collect a sample, you send it off for refractometry to try to break down its components and then extrapolate backwards what that is. Then you need to measure a dose and a disease effect from that dose. And then you need to kind of have an idea of how often are people in this environment and how often are they not in that environment. So many of these controls around it. So it's very data heavy. You then need to extrapolate into the human what these effects could be. And for that, you're doing audiograms if you're concerned about hearing. You're doing lung function testing if you're concerned. Just a lung function test, and our challenge of many of our colleagues, how many data points are there in a lung function test? Starting with your age, your gender, followed by a flow volume loop, and so on. So all of these pieces, they need to be brought together into some kind of picture. This is what I'm exposing people to. This is what health impact I think is going to occur from that. It happens over a long time, so there's only incremental change. You don't see this change often immediately. You see it over multiple years, over multiple sample runs. You need to maintain quality across all of those sample runs. It's a tough job if you really want to do and look after your data in the best way possible when you think about it. I think you and I were talking last night about measuring height, So the simple quality test I always do is pull up a longitudinal record and look at what the height measurement was. A good quality service will only measure height once and never measure it again because your height doesn't change, for your life. But the ones that don't know what they're doing, measure it every year, And then longitudinally, I always check to see what's happening to the height, And if it's changing every year, then I think you've got to, we need to start looking more at the rest of your data. And there are numerous studies to say, if you look at hearing testing databases and the amount of variation, both in person and from a testing perspective, lung function testing, I mean, that's one I can go on for a long time on that, but it's a lot of data. And a lot of data that you need to manage quality for, and a lot of data that you could infer a lot better. I don't think we do as good a job as we could with it. It's expensive, and it takes to get it right, But it's there, and that's the most important part, is that you do have this data and you can start to draw conclusions.
The other related challenge is in the era of big data, and you say it's always been big, but I think objectively it's grown. So we now collect more data than we were doing 20 or 30 years ago. We have a lot of data that causes its own problems, because now you can't not know. We have all these indicators. They are longitudinal. There are changes over time, but there are also other changes between different cohorts within your workforce, and also changes within the same person. If you have been collecting it, it would be unethical to pretend it's not there. So we have a duty to at least analyze it and try to make sense of it and ask ourselves, what does it mean? Is this good news? Is it bad news? Is it neither? Maybe we don't have enough information yet, so we need to keep collecting. And so I guess my question is, I don't know how you are not a statistician. Like, how do you do this given that you didn't formally study statistics? Or is the answer, whether you like it or not, you're kind of forced to become a self-studied statistician, otherwise you can't do your job properly?
Yeah, I certainly don't believe you can do occupational medicine properly. But by extension, I don't think you can do medicine properly without a good grounding in statistics. So, and to be fair, we all, I think, well, look, it depends on where you studied, but I think most undergraduate courses in medicine, and as was mine, we did do epidemiology, biostats, and also at a postgraduate level. So we spent some time in the diploma in occupational health, for instance, and I know, and across most of the studies, including business studies, you do it, and like I said to you, that's probably where I rediscovered. It was more embarrassing at how little I knew about statistics, given what I do, and probably what was really interesting for me was a book called Bad Science, and I recommend that book to everybody, because I think that's what got me back into my journey in statistics. And the author is a guy called Ben Goldacre, who's a psychiatrist, and he's got a chapter in there. It's called Why Smart People Believe Dumb Things, and that particular chapter covers the common statistical fallacies that we, and I thought when I read that chapter, I'm not a dumb person, and it was quite enlightening that I was one of them, So, and I think that was a personal challenge for me. So, just to get back then to you, for instance, let's take the hygiene data set that's pulled up when we measure noise or dust levels. We collect all of these samples. These are then analyzed. They're put into a statistical package. Probably the commonest one that is used is one called IH-STAT, or Industrial Hygiene Stat, that is developed by the National Institute for Occupational Health in the US. And inside this are a number of statistical tools that are used for the hygiene data. And one of them is, it's a right skewed, that often exposure data is right skewed. So these are all of the various tools. You need to decide whether there's a big debate on Bayesian versus frequentist approaches, and the relative merits of each approach in occupational health. So I think a lot of probably doctors are focused on the medicine part of this, but don't spend a lot of time in the hygiene part of it, but all of the longitudinal data that you are collecting in the medical facility, I see very few facilities applying statistical techniques to their longitudinal data at both an individual and a population level. A lot of it is observational. A lot of it is what when you just to answer one particular question, and the word will come back to me. I forget. But there's a lot of, and all of that data can be subjected to statistical analysis. In fact, I was looking at just just towards the end of last year, we were looking at some of our biological monitoring results. And it struck me that I couldn't just draw a conclusion on this data without testing it statistically. So observationally, I could tell you that, levels are elevated, but what's the difference between the unexposed and exposed groups? And the team hadn't thought to subject the health data to the same techniques before we draw conclusions. So I do think it's used in hygiene. It's almost accepted that this is the statistics are thing in medicine, except in the study in research. But on an operational level, I see very few people using that techniques, and I say we don't use it as much as I think we should be using data that way. But there are also limitations to your data set, okay, which we can talk about as well, if that comes up.
Yeah, so one of the things that I trust will resonate with you is when you transition. So my path was I studied statistics while I was still in med school because they had just opened a new program which they called the Masters after Masters in Statistical Data Analysis. So you had to have a master's under your belt to be allowed into this program. And I was in 5th year of med school, and I contacted the organizers and I said, I'm not yet graduated, but can I just follow along? And that's how I got into statistics. So I remember the theory and I remember doing the classroom examples. The big gap between what I learned in that master's and what I'm seeing today is that the data was hardly ever incomplete, was hardly ever imprecise, and never made no sense. But in the real world, it's never complete, it's always imprecise, and it sometimes makes no sense. And so in the statistical course, you don't get taught how to deal with that real world imperfection part of the equation. So you've already alluded to people measuring height imprecisely. But what about self-selection bias? So the people who have the biggest complaints get measured, and the ones who don't have a complaint don't show up, and their data is not part of the data set. And now it looks like you have a very sick population, but all the healthy people are not part of your data set, for instance. How do you deal with that? Or there's attrition. So the people who are very adherent stay in the data set, and the people who are not adherent leave the data set. So it looks like the treatment is working because for those for whom you have 5 years of data, things get better. And the ones for whom things didn't get better are no longer part of the data set. So does that sound like things you have also had to grapple with?
Yep. And so what you in occupational health, that effect is called the healthy worker effect. It has got a number of implications, that workers are generally healthier than the general population, number one. Number two, even though amongst those exposed, those self-select out in their early careers against exposures that are making them sick, if they have a choice, is often, depending on how scarce or available work is and options are, where one of the factors that drives occupational disease, because people cannot leave, they are obviously getting a allergic rash from welding or hairdressing, but it's not so easy just to opt out of that career. It's all they know. It's all they've been doing, so they keep on doing it. So you see a lot of so I think those are fascinating and important insights into occupational health and how it works. So we, in general, would see less noise effects for, we monitor for it, but those people who shift work is another good example. Probably one of my observations is that we have certain illnesses, and the harder it is to actually pin down, particularly if the symptoms are more can be symptoms of a number of other disorders. So let's take circadian disruption and its impacts. Okay, most of the effects, but metabolic derangement are also the effects of a poor diet and unhealthy lifestyle. and it's disentangling what is caused by work from what is caused by non-work factors. That is an important and becoming more and more important as we go forward. So, I mean, I can add on to what it is that you're saying. And if you ask me, probably what's becoming more and more of a challenge, the old days of silicosis and asbestosis and noise-induced hearing loss, but even noise-induced hearing loss, I would say the line is getting blurred between non-occupational exposures and occupational. So how much of this hearing loss is by you wearing your earphones too loud versus from what you're being exposed to at work? Your depression, what percentage of that is caused by the working environment and the psychosocial work environment versus your work outside, your life outside of work? How much is the relationship between your work life and your non-work life? How are the two interacting and impacting each other? Those, I think, are going to be the most, and I would argue we're not even on top of physical, easily measurable hazards like noise and like dust. And it's going to become even more difficult when we move into the realm of psychological conditions where it's symptom-based. There's no objective way to say that this individual has or has not got, it's a set of questionnaire and an interaction. So, and I would say, yeah, it's going to be even more because the days of classical occupational health are probably behind us. Workplaces are a lot safer. We're doing a lot more for the physical hazards that our employees are exposed to. And as we're moving into a realm of exposing them to a different kind of a hazard, how do we start to disentangle that? So in summary, it's going to get even more difficult. So everything that you're saying, Wim, and more in these populations, and things like the Haythorne effect. I don't know if you remember, that was an early experiment in workplaces where they exposed people to different levels of lighting and measured their motivation and showed that, in the end, just doing something, good or bad, was positive. And it's managing all. So it's a fascinating environment. And all of these, and I would say probably if you had to give me just one line is we don't spend enough time in this part of occupational medicine outside of the research setting. So you see a lot of these papers being published every month on a variety of topics, but often they're not answering the real everyday questions and many of the common questions that we see all the time.
Okay, thank you. You've triggered a lot of thoughts. One is, before I forget it, I want to share with the audience that in September, for those who are able to come to Cape Town in September, we are having a summit on the topic of causal inference from observational data. And that's exactly for the reason that you were describing, that we have all this observational data, we want to learn from it, and we want to disentangle confounders from causes, from intermediate mediators. And that's hard to do, but statisticians have been working on this question or on this challenge for a few decades now. There's a whole bunch of methods that have been developed, and they're not typically taught in even undergraduate statistics degrees. So you can be a degreed statistician and still have had very little exposure to causal inference. And so we organizing this summit in part to make leaders like you more aware of what exists and what can be done to do more with the data, but also to train the technicians, the data scientists, the business intelligence experts with the methods that they might not even be aware of, so that we move beyond line charts and pie charts and we move in the realm of causal estimates, which should then be the source for new experiments. So if A causes B, then it should be that if I change A, I should also see a change in B. Let's test that in an ethical and in a structured way in the workplace. That's, I think, where we must move to. So that brings me to something we also discussed in preparation of this conversation, and that is we measure so much, but sometimes we don't act enough on what we find. So we see people who year after year show up unfit, hypertensive, overweight, sleep deprived, and we make a note of it. We at best share it with the patient or with the coworker, but whether they do anything about it or not, it's kind of out of our hands until we see them again the next year. So my question, and I know there's this tension because you're not necessarily their chosen GP, right? So you, as an occupational medicine specialist, you also limited in your ability to own the health pathway of that employee. So what do you believe is the way forward so that it's not very disempowering and you see all these unhealthy employees and you kind of observe it and you can't do anything about it? What is your role and how do you play, how do you facilitate other parts of the health system where maybe there's more agency?
Yeah, and it's a fascinating point again. And probably, starting off I started my career in South Africa, and I've spent most of my career there. There's less and has always been very little distinction between the occupational health record and the other countries. Not so. If you go to Australia, there's a very tight control over what is occupational data, what is non-occupational data, and so on and so forth. And strictly speaking, in occupational health, you should be focusing on just that set of data that is related. And to touch on your causal conversation earlier, we have the cause, so we often can, like in the case of noise exposure and then noise effects, we've got both the exposure and the effect, and we're meant to be, that relationship is supposed to be tight. However, there are a number of other causes of the effect. And that's probably what you're trying to disentangle in causal studies. But in practice, and this is my personal perspective on occupational health, is that occupational health is a public health discipline looking after the health of the working population. Some of those effects come from work directly. Some of them are public health outside of work factors that happen to be seen in the workplace. And I feel a responsibility to at least act on the system to improve that. And in a company, for instance, as if you senior enough and a chief medical officer, and I'd say in many of the big companies in South Africa, this is the case, but and less so outside of South Africa, in my experience, you control both the health benefits or the how we pay for health outside of occupational health, and you have influence over that system. In some systems, when I started at Anglo Gold, and many of my South African colleagues on this call control both. Those employees, this is their GP, as well as their or at least it's one department in the same hospital. So I think there's a big responsibility on us to, and I'll say that medicine and occupational health is moving closer and closer towards this, seeing the person as a one single person. It's called health and human performance formally, which is when occupational health starts to dabble in non-occupational health things for the Americans who like to see these things differently. And for a lot of us, if you practiced in Africa for any period of time, you'll know that we probably manage both at the same time. And we see, definitely in my early career, HIV was my biggest single problem. And the interaction between HIV, TB, and silicosis in the gold mining industry, for me, is a classical example of how it's really difficult to disentangle work exposures and non-work exposures and how they work together, And the same example can be made for noise exposure, mental health, and your metabolic derangement. So there's, being exposed to noise increases your blood pressure, right? Up until it's not really generally accepted that cardiovascular disease and noise exposure are causally linked. But you imagine, I don't know if you've sat and listened to low-level noise, 60 decibels in the background. It's very irritating, So I think there's a lot in that space that we could still disentangle, and even in what we think of physical or truly physical hazards, but and to get back to your point, I think we have a greater duty, in my opinion. Okay, so different people will have different perspectives on what their role is. In the UK, it tends to be quite, hey, that's go and see your GP for this problem. There's that handoff, and interestingly, the NHS is facing significant challenges. So even the UK government is now starting to re-look at the entire system, because the occupational health, this strict line between these services is not necessarily helpful, in my opinion. Okay, I know there's had to be many opinions on this.
Thank you. So I want to invite the audience to type any questions. As you can see on top of your screen, there should be a Q&A tab. If you can't find it, but you can find the chat tab, that's also fine. And while you type your questions, I want to close off with the final one, and that is about AI. So you've already, I think, the last thing you said about irritating noise at 60 dB. So 60 dB is well under the cutoff that any occupational medicine specialist would cite if you ask them what is risky noise. And so I think that's very important, because it points to the notion, the fact that in life and in medicine, we constantly use cutoffs, but nothing behaves in a clear-cut black and white way. It's not true that 79 dB is safe and 81 is unsafe. That makes no sense. Nothing behaves like that. So 60 long enough may have worse consequences than a little bit of 85 dB once in a while. So this is where the rule-based classic statistics may fall short, and where if we now use language from AI and machine learning, if you just share the data with an algorithm and say, find me associations, I don't know what you should be looking for, but you look for it, so-called unsupervised learning. You might find associations that are surprising, because you didn't tell it, only find me the people who've been exposed to more than 80 dB for longer than so many hours. So with that said, what is your view on the use of machine learning algorithms and other AI tools in occupational medicine? Are you a proponent? Is it dangerous? Should we stick to the old school things? How do you see that?
I'm a big fan. I'm the opposite, So I think and it would be interesting to look at, perhaps one other time, what is AI and the types of AI, because, large language models are just only the one aspect of it. And, the expert systems, I think, for instance, that's probably number one, where we could take out occupational health is one of those specialities where we could reduce significantly the workload. Let me not say remove, okay? We could easily put all of that data into a machine, because literally, if you, for most of what you're doing, you are following some kind of rule-based algorithm, in your mind, and then it's a few cases where you need to truly apply your mind in this case. But most people, in fact, who come into the occupational health clinic in general are healthy. You don't find anything wrong with them, for example. So with the amount of heavy data we have, this speciality is ripe for a massive transformation when it comes to all aspects of artificial intelligence. Exactly like what you're saying now, So if you could release an agent on all of my health records, my wearables data, my exposures at work, one of probably my favorite one is let's take South African law, but most countries are like that. You are supposed to inform employees of their exposure, It would be really interesting how long it takes before we can in real time be delivering this information to our employees to tell them, yesterday, this was your noise exposure at work. Very much like what you have on your Apple iPhone already now, if you're using your earpods, it tells you what your noise exposure was and how high it was, you know. So those are good examples for me. So I think there's tons of, it's a really exciting space, you know. And in many ways, it's always been that way, you know. Probably the biggest transformation was to move from paper into electronic records. But once that happened, much information is kept in large structured databases in occupational health, especially for big companies. I'm not saying this is the case for everybody, but we have one global occupational health record that holds our information. And many of our large peers have the same data, you know, and it's structured data. You know, it is a really happy hunting ground for this. And given that how data heavy it is, you know, it's other factors. It's investment. Do people want to know what this information is? You know, is a very important one. You know, do you really, or do you want to just collect the minimum data? And what will you do with this information once you have it? Exactly like what you were saying, because you're obligated, you know, to do something. But in South Africa, as a good example, you are required quarterly to send all occupational health, all occupational hygiene monitoring results to the government, for instance. So there's a lot of data sitting there that, in theory, anonymized, is publicly available, where you could start analyzing what's going on there, you know. But yeah, but I think it's one of those fields. I think it's like radiology in many ways.
Thank you, Elton. Can we go through the questions? We've got 4 questions and 6 minutes, so let's try to see if we can get through it. So the first question is, noise has been shown to increase blood pressure over time. NCDs are on the rise globally. Will we get to a point where NCDs are seen as work-related, requiring Section 11.5 and compensation? It would be interesting to do a study comparing blood pressure readings and noise exposure over time. I'm not sure if you can comment on that.
Well, I would say you're assuming the person's only exposed to noise, and I would say you'd have to disentangle. So we'd have to move to a point where it could be much easier to calculate exactly how much all of the factors that affect your blood pressure are, and what contribution was your blood pressure towards you getting the non-communicable disease of interest. But that summarizes probably for me the fundamental challenges in occupational health. So who's to say it was the noise only that did that? Who's to say it's not, you know? And I think better data, analyzed correctly, controlled correctly, good quality data is that way. We're not there yet.
Okay. The next question is about the global complexity. So across 60,000 workers in different jurisdictions, how do you standardize health data when every country has its own regulatory format?
With difficulty. So, and I'll tell you the most, I take a science-based approach. What does the evidence show, you know? And then you must always comply to local law, but law follows its own dynamic, its own way of being generated. What is legal is not necessarily scientific. What is scientific is not necessarily legal, you know? So you need to apply your mind. I'm a doctor. I take a medical and a clinical view to what we do. What is this level? What does the evidence show? Does it cause this disease? And then I look at the law, you know, and act according to what they say. Sometimes that law doesn't exist in many of the countries in which you operate, or it hasn't been changed in many years. Evidence has moved on, the law remains the same, and so on. So at our core, we try to be science and evidence-based while recognizing that you cannot act illegally in countries, but at the same time be prepared to challenge. And some of us are big enough that we can go to the lawmakers and the regulators and have a conversation to say, hey, time we change this or not, or introduce this or that, okay? So, yeah, I hope that answers the question.
The next one is about the need to capture, document, and report what you're doing. How do you go from having the confidential medical data to reporting about it without breaking confidentiality?
Yeah, so I think once again, and it's one, I think people need to, if you read GDPR correctly, there are allowances for occupational health data because, we didn't discuss this, Wim, but when you're doing proper, good quality occupational health, you're actually looking for sentinel cases. You're looking for signal in the noise, So you really are doing a study, okay? So that means when you take consent, you need to be cognizant of, hey, we may use your information to identify new trends. New trends may emerge from the data, which we didn't consider when we first started medical surveillance on you. And you need to put that into the consent, So I think we need to think about when we're taking this data, what are the implications? And it's 2026 now. We know a lot more about what we can ask people, And then technically, there's many methods of anonymizing data once you have it, linking up various data sets. Fascinating is to link the occupational health record to the human resources record, like performance, where that can be measured accurately. How is health affecting performance? You can do that in the background, and blockchain is one of the technologies used to anonymize this data. So there's technical ways, but there's also the human element and talking to people about what it is that you're doing and why do you want their data, and collecting the least amount of data you need to draw the conclusions that you need to do. All of the hard stuff that I don't think we do enough of.
Yeah, but I think your keyword was informed consent. So if you are proactive and you're already saying we collecting this data with these purposes and future usages in mind, then I think you have already won more than half of the battle.
Absolutely.
Yeah. And the last one is, do you see the opportunity to integrate environmental exposure data from mines with worker health monitoring data to create predictive health risk models?
Absolutely. So we talk about in occupational health, the sensitive receptor, where does that lie? And environmental health is just an extension. And in fact, people no longer speak about occupational. It's now occupational and environmental health, and that's becoming more and more the term that's being used because these are so similar as fields.
Yeah, I think maybe to bring it back to our very first comment and your mention of the COVID pandemic, I think that in some ways is a prime example of that, because when we were building these models for trying to manage the exposure risk on the work floor, we couldn't pretend that COVID in the work floor has nothing to do with COVID in the community. So the incidence and the prevalence and the vaccine coverage that we believed was true outside of the company influenced the risk that people were exposing each other to while they were seeing each other in boardrooms and in mining shafts. So that's, I think, a very real world example of where we had to integrate both to come to a science-based estimate of what the incidence might be over the next weeks or months, in the absence or in the presence of various preventative measures, including vaccines.
True. Yep.
Great. Thanks. Elton, you wanted to make a
comment? We're over time now, but we could have a long format engagement on this particular one. Yeah.
Yes. So I want to thank you for your time. We covered a lot of topics. I trust that it was insightful for our audience. And I want to also thank everyone for joining and staying on the call. And Elton, I wish you all the best in all of the endeavors and all of the proactive, pioneering, preventative interventions that you're leading at Rio Tinto. And looking forward to the next time we chat.
Thanks, Wim. Thanks for having me, and thank you.